we're going to discuss the pulmonary system. So when we look at the pulmonary system, the main things we're concerned about are your airways and your lungs. So structures of the pulmonary system, we start off with our trachea, that's our windpipe. It then splits into your main bronchi, right? And then we just keep splitting and segmenting further and further down. So we go trachea, bronchi, right? Then we get subsegmental bronchi, so each of your main bronchi will segment more. Then we get to bronchioles, right? And then we get all the way down to your alveoli, or the tiny little air sacs of your lungs, right? They will look like little clusters of grapes sitting off of your bronchioles. Their job is gas exchange, right? So they're surrounded by capillary beds, and this is where the teeny tiny arterioles cross over with the teeny tiny venules, right? And that's where they drop off CO2 and pick up oxygen for our gas exchange. Right, some key concepts to remember with the pulmonary system. We have inspiration and expiration. Inspiration is when we draw air into our lungs. Our respiratory muscles get stretched, so our chest wall expands and opens up. Our lung tissue is elastic so that it can expand and pull air in during inspiration, and it's made of collagen fibers to make them stretchy. This is when oxygenation occurs. This is when we get oxygen into our lungs. Expiration is whenever the lungs contract, right? They recoil, right? Think of it like a balloon. You blow it up, you stretch it, you let go, and it contracts and bounces back. All right, so it's a passive action. Air gets moved out of the lungs. The chest muscles and respiratory muscles recoil or spring back to their relaxed original shape. The chest gets smaller. Our intrathoracic pressure goes up to push air out. All right, so whenever we expire or breathe out, we remove carbon dioxide from our lungs. So if we have a problem with oxygen saturations, that relates to inspiration. If we have a problem with CO2 levels, right, that relates to expiration. All right, so our main focus is the exchange of gases, right, at the tiny alveolar level. This is where we get rid of CO2 and pick up oxygen, all right, and it's across that alveolar capillary membrane. Right? Ventilation is the movement of gases in and out of the lungs, or the movement of air in and out of the lungs. When we have decreased ventilation, whenever we don't have enough exhalation going on, right? This is going to change our CO2 level, right? It can be hypo if we're breathing out too much and blowing off too much CO2. It can be hyper or high CO2, that's hypercapnia, right? If we're not breathing enough, and then our ventilation is impaired and CO2 builds up. Perfusion relates to blood flow to an area. We have decreased perfusion when we don't have enough blood flow in that alveolar capillary membrane. This is going to lead to oxygen not being able to be picked up, and then we're going to have low oxygen levels known as hypoxia. We need to maintain a balance between our ventilation and perfusion. You'll see this abbreviated in medical text as VQ, right, for gas exchange to occur. It's related to the VQ, or ventilation perfusion match. Right. What they're talking about is that we need to have an adequate amount of perfusion as well as ventilation going on in order for gas exchange to occur. If we do not, then we impair our VQ ratio, or VQ match. Right. So for instance, if we have a blockage to our air sac, right, this is symbolizing that we have a plug. Right, then we don't get any air or gases exchanging in here. So we have perfusion, it comes in, it goes around, but it goes out without ever getting oxygen. Right. Over here, the opposite. We have gas, it's coming into the vent, or into the alveoli, right? But we don't have perfusion because it's blocked. Right, so then we have no perfusion to pick up our exchange of gases. Right. When it works correctly, we have gas exchange, we have air movement, and we have perfusion. All right, then it works well. We get rid of our CO2 and pick up our oxygen. Right? If they're mismatched, then we don't have that. Okay? Obstructive lung disease is a class of diseases of our lungs that are going to obstruct airflow and ventilation to occur. Right, so something is going on where we have increased resistance to airflow within the air sacs of the lungs. Right, that's obstructive airway disease. COPD is also chronic obstructive pulmonary disorder. It's a respiratory disorder where we have a gradual, progressive reduction in the ability of our lungs to exchange air. Right, it's actually a combination of two different airway diseases. The patient would have to have emphysema and chronic bronchitis at the same time, and then they get diagnosed with COPD. Asthma is also an obstructive lung disease, right, but it's our only one that could be reversible, right, and manageable. So let's start with asthma. Asthma affects about 1 in 12 people in the U.S. That's about 8% of our population. You or someone you know probably has asthma, right, or has had to deal with it at some point in their life. About 1 in 10 children, about 10% of our population, has had asthma. Right, 1 in 12 adults, that's where we get our 8%. It's the leading cause of chronic illness in kids, and it's the number one reason that kids miss school. Right, there's more than 8 million kids affected. Right, it's most prevalent in African American children over Caucasians. It increases in children who have allergies. Right, that's considered a risk factor, and it most often starts as a nighttime occurrence. We're going to talk about bronchial asthma. Right, so bronchial asthma tends to be familiar. We see it in families. Right, it's linked to more than 100 genes though, so we don't know specifically how to measure inheritance. We just know that we see it linked in families. Right, it's the one that's triggered and has flare-ups because of triggers like emotional or physical stress, environmental pollutants. That can be things like smoke, pollen, exhaust, emissions, things like that. Respiratory infections can cause flare-ups. People who live in urban areas tend to have higher incidences of asthma than out in country or rural areas. And it can also be related to reflux or gastrointestinal reflux, GERD disease as well. Okay. With bronchial asthma, there's going to be episodes that have flare-ups where they're going to have airway obstruction, right, that causes their bronchial linings to be hyper-responsive, and this leads to them getting spasms and inflammation of the airways. It's often triggered by mast cells. They release or trigger histamine and heparin, right, which causes the inflammation. We see an increase of white blood cells to the area, like eosinophils, basophils, macrophages, things like that. This recreates the inflammatory response that we learned about in week 1. Alright, so the inflammatory response then changes our capillary permeability and stimulates smooth muscle secretion, which releases mucus. So these are our normal airways. When someone's having a bronchial asthma attack, their airway reacts to a trigger, right? It could be an allergen, emission, something like that, right? This causes inflammation. That means that their airway, smooth muscle, gets inflamed. So now the diameter, or their breathing hole essentially, is much smaller, right? They often feel like they're trying to breathe through a straw or a tiny airway, right? The capillary permeability increases, which increases swelling, right? It also stimulates smooth muscle contraction, so then we're going to have spasms, right, which clenches down these muscles and narrows them even further. And the permeability also increases mucus. So now we've taken fluid and put it into these tiny airways, making it even more difficult for them to breathe. Right. Inflammation is a major pathologic problem with this disorder. Right. It's from that hyper-reactive or hyper-responsive reaction to a stimuli. Right. Inflammatory mediators get released during the asthma attack. They're usually histamine, prostaglandins, and leukotrienes. This causes the smooth muscles to spasm, the congestion of the vascular beds, and the permeability to be increased. The airways swell with edema. They get thick mucus production. The mucociliary cells, those little hair cells in our air tracts that help move mucus along, get paralyzed and they can't work. The air walls get thick, and all that makes that breathing hole that they have in their air sacs even smaller and more difficult to exchange gas. All right. So the airway obstruction means that we're going to have resistance to airflow. Just makes it harder and harder for air to move in and out of the lungs. All right. This causes hyperinflation distal or past the obstruction because air can't get out, all right, and increases the work of breathing. So we have a decreased ventilation, which means we're going to see CO2 levels climb. All right. The air trapping is going to increase as they try and suck air in, and they have a decreased perfusion. Hyperventilation is going to be triggered because the lungs are going to be trying to replace all of this gas exchange problem. So they're going to signal that they need to breathe faster. All that does is increases the air trapping and causes more problems. What we see then is hypoxemia without CO2 retention at first, and then it's going to cause CO2 levels to climb after. Right? If left untreated, it's going to cause irreversible damage to the lungs. This is just another image to help you see. This one, the little waves, these are the bands of smooth muscles that have the spasm that cause even more narrowing. And you can see again the inflammation and the mucus formation in the airway. Alright, so asthma is a chronic problem. It's an inflammation issue and it's constrictive to the airways. Next up, we're going to pick up with clinical manifestations of this disease.